leading pathology, or you can say in the genital region in the female. Uh, as we did in our last lectures, that regarding any tissue or any organ, you have inflammatory diseases, you have congenital diseases, and then you have certain tumors. So, regarding inflammation in cervix, it can be inflammation which is solely related to the cervix, or it can be part of the inflammation from the surrounding structures. It can be part of the pelvic inflammatory disease, which we discussed last time. Uh, the inflammation, as we did in third year, can be acute or can be chronic inflammation. Mostly the acute inflammation can be bacterial cervicitis, which is something very rare. It can be a parasitic inflammation, like Trichomonas vaginalis infection in vagina, or it can be because of certain viruses. But in case of cervix, mostly the inflammation is chronic, it is viral induced, and one of the culprits is human papilloma virus. Human papilloma virus, as we did in third year, is one of the viruses which can infect cervix and many other regions in the body wherever there is stratified squamous epithelium. So you may have virus which can cause benign lesions, inflammatory lesions actually. Then there are certain strains of the same virus which can cause tumors. There are certain strains which can cause benign tumors, and there are certain strains which can cause malignant tumors. So it is very important that if you have HPV infection and there is a diagnosis of HPV infection, the histology is important, whether there is dysplasia in the tissue or not with the inflammation, and you have to go for the strain of the virus to follow up the patient. So this is a colposcopic view of cervix. This is the view a gynecologist can see in lithotomy position. This is through colposcopic examination, which is an outdoor examination, or you can do this in the daycare operation theaters. So cervicitis is going to show you redness and signs of inflammation. There can be swelling, and an important thing is a discharge, as we did in our last lecture, that the color of the discharge and the consistency of the discharge is very important and can lead you there and then to the diagnosis. Like if it is a yellow colored discharge, it is that the infection is a bacterial infection. If it is a white creamy discharge, it is a fungal infection, and the most important fungus is Candida albicans. And if it is a foul smelling greenish discharge, it is Trichomonas vaginalis. So the infections in the vagina can also involve the cervix. So the color of the discharge and the consistency of the discharge can lead you to the diagnosis, and you can start the treatment there and then. This is a colposcopic view of the cervix, and you can see this white creamy discharge. This indicates that this is a fungal infection or candidiasis, which we call a vaginal thrush. Again, this is showing you a picture of vaginal candidiasis involving the cervix also. This is this is the acto cervix, and this is the discharge. Again, these are some of the pictures showing you the colposcopic view of the cervix. You can see that the discharge can be uh, white or cheese-like, white creamy, which is a fungal infection. The discharge can be serous or discharge can be blood stained. So if it is blood stained, that can be because of number one trauma, and then you can think of a malignancy. Malignancy can be a cervical malignancy, can be endocervical malignancy, or can be a tumor in the endometrial cavity. That endometrial tumor can be a polyp that is ulcerating and bleeding, or can be a malignant tumor of endometrium from where the discharge is coming. So a discharge on colposcopic examination not only indicate that it is cervicitis, but it can be an endocervicitis or any lesion in the endometrium, which can show you a bloody discharge. This is just to show you the microscopic examination of a biopsy from the cervix in case of an inflammation. However, in acute inflammation, you don't go for a biopsy, you just treat the patient according to the color and consistency of the discharge. There is no need of biopsy in acute inflammation. It is going to further aggravate the lesion. So you are going to take the biopsy in cases of viral infection, or whenever there is no discharge, or whenever the cervix is not inflamed like in the acute. So in acute cases, you always first treat the infection and then go for a biopsy. So this is ectocervix, which is stratified squamous epithelium, and then you have this blood and inflammatory cells. Again, this is chronic cervicitis, showing you an an endocervical lining, which is columnar, and then in the stroma you have a lot of lymphocytes and plasma cells. Another lesion on the cervix, just like the vulva, is a swelling of the gland, which are Nabothian glands in the cervix. We have Nabothian glands in the cervical stroma, which they have got small ducts which are opening on the surface of the cervix, and they produce a mucus-rich secretions. Sometimes, if there is blockage of the duct, the gland may dilate and form Nabothian cyst. This is a picture showing you a colposcopic picture or colposcopic view of Nabothian cyst. And if the cysts get infected, they are going to form an abscess, which you call a Nabothian abscess. You have to go for excision both in the cases of a cyst and in the cases of abscess. And in cases of abscess, you may then go for an antibiotic treatment. See this, this is a colposcopic examination of the cervix, and you can see a swelling, uh, bulging on the actocervix. So this is a Nabothian cyst. See this. This is a histological view of the entire cervix. You have actocervix, and then you have endocervix on the other side. Endocervix consists of columnar cells and secretory glands, while ectocervix is composed of stratified squamous epithelium. You have Nabothian glands underneath the ectocervix in the stroma, and then there are ducts opening on the ectocervix. This is a dilated gland with secretions, which we call Nabothian cysts. Cervical cytology is called pap smear. This is by the name of the scientist Papilloma, who first formed or invented or proposed the stains for cervical smear, and the cervical smear is called pap smear, and the stains which we are using are called pap stains. The full name of the scientist was Papinoculo, and you call it Papinoculo stain. So you, in short, you can call it pap stain or pap smear. So pap stain can be done for other cytology slides also. So it was first proposed for cervical cytology, so that is why it is related to cervix. But you can do pap stain on other FNAC slides or smears also. So cervical cytology examination can detect HPV, or can detect infections, or can detect abnormal cells which can be low grade malignancy or a high grade malignancy. We are going to talk in detail in the next few slides. So a cervical smear is taken by a spatula. It is taken in a lithotomy position through a colposcopic examination. First, you have to view the vagina and the cervix, and then you have to uh, take smear through this spatula. This is a wooden spatula or a plastic spatula, and then there is a brush. If you take, you are going to insert this end into the cervix. This end is going to insert into the the ectocervix. This is going to insert into the endocervix. So you are going to have a representation from both the epithelium. So a cervical smear is going to contain cells from ecto and endocervix, and that is how a pathologist is going to call that smear an adequate smear. If you insert this brush into the cervix, this is called cervical brushings. So colposcopic examination, lithotomy position, you are going to insert the spatula, you are going to rotate the spatula in the ecto and the endocervix, and then you are going to smear those secretions and the cells on the slide. So this is how a cervical smear or a pap smear is taken. So you must have a representation from both. If there is a discharge, or if there is bleeding, or if there is excess of mucus, you have to remove those discharge or the mucus or the blood first, because it can hinder in the cervical or the cytological examination. Sometimes we get slides which are full of mucus and blood, and we cannot see the cells properly. So that is just an inadequate smear, and there is no benefit for the patient. So the smear must contain the cells which are visible. So as I told you in the initial slides, that in cases of acute infection, you don't take pap smears, you just go for the treatment first and then go for a pap smear. So this is cervical brushing. This is colposcopic examination, and the whole procedure. Colposcopic examination, you go in with the spatula, you just rotate the spatula, and then spread the smear on the slide. This is how we see the cervical smear. You have a representation from the ectocervix, that is that you are going to have cells from the stratified squamous epithelium, and then you are going to have cells from the endocervix. That means that you are going to have cells which are columnar. So both the sides means that the smear is adequate. So in this slide, you can see superficial squamous cells with a small nucleus. Then you can see the intermediate polygonal cells from the stratified squamous epithelium, and then these small cells are actually the neutrophils, showing you that there is an acute infection. This stain is pap stain or papinocular stain. This stain is actually staining the cells in different stages of their maturation. That is why they have different colors. So this is a normal smear showing you a superficial squamous cell with a small nucleus, intermediate cell. This is a metaplastic cell from endocervix. These are endocervical cells. So this is a good, adequate smear on which you can comment as a pathologist. If you have all the cells, then you can say whether these cells are normal or these cells show any abnormality. If you have only superficial cells, still it is an inadequate smear. If you have only endocervical representation, still it is an inadequate smear. The colors of the cells, as I told you, is because of the maturation. This is glycogen in the cell, in the superficial cells, which stain pink and then orange in color. So, a comparison of the two smears. This is a normal smear showing you superficial cells having a small nuclei. These are few neutrophils here. Then this is an infected pap smear. You can see cells which have a lot and lot of glycogen and they stain orange. And then you have a nucleus which is larger than the normal nucleus. You have inflammatory cells here, a lot and lot of inflammatory cells, and this is an abnormal smear. See this, you have normal cells here, you have normal cells here. Then compare these cells with these cells. These are abnormal cells and you have a large nuclei. This is an abnormal mitosis. So this means that these cells are not normal. This is a pap smear showing you a lot of or sheets of neutrophils. This pap smear is going to be reported as an acute inflammatory smear. So this is an acute infection or acute cervicitis. See this, that because of these inflammatory cells, you cannot see the cervical cells properly in the background. This is again an acute inflammatory smear showing you a bacterial colony. This is actinomyces, as we did this in granulomas in third year. So actinomyces or actinomycotic infection is one of the common infections in the cervix. So you can see this and you can report this on just pap smear. This is These are normal squamous cells, and these are the squamous cells infected by human papilloma virus. This light colored cytoplasm actually means that this cell is infected by viruses. Viruses cannot be seen on the light microscope. So actually, this cytoplasm is studded with numerous viral particles. That is why this is enlarged, and this cytoplasm is lighter in color. If you see the same cell under the electron microscope, it is going to show you the viral particles. And there is a bit of dysplasia. Dysplasia means the enlarged nucleus. It is not like normal, and it is not a small nucleus in the center. It is a large nucleus. Cervical smear is not a biopsy. We are not taking a tissue. We are just rotating the spatula on the epithelium or a brush on the epithelium, and all the desquamated cells are going to come in the smear, and you are going to spread that on the slide. You are not taking a biopsy, you are not taking a chunk of the tissue. So you are actually taking the desquamated or fallen off cells. So it is a non-invasive procedure, giving you a lot of diagnosis for the treatment. So you have normal cervical smear, you have inflammatory cervical smear, then you have certain cervical smears which can indicate precancerous conditions, and then you have a full malignant cervical smears. So this is just to show you ecto cervix, which is stratified squamous epithelium. This is normal. If you take pap smear, you are going to see cells from the upper layers. This is mild dysplasia. You can see cervical intraepithelial neoplasm, that is a neoplasm developing in the epithelium but not breaching the basement membrane yet. So it is not an invasive carcinoma yet. So you have moderate dysplasia, which is called CIN2, and you have a full thickness dysplasia, which is called CIN3. This stage is called carcinoma in situ. All these three stages, if you remove the cervix, the patient gets the benefit that she is not going to develop any metastasis because the basement membrane was not breached. So this is beneficial for the patient. Again, this is a scheme to show you the normal uh, epithelium. Then you have two terms which are used nowadays in the PAP cytology or the reporting. One is called low grade squamous intraepithelial lesion, also known as LCIL in abbreviation, and you have high grade squamous intraepithelial lesion, which is HSIL. If you have viral infections or you have grade 1 or moderate, or sorry, mild dysplasia, you are going to report it as LCIL. And if you have a high grade dysplasia, moderate, or carcinoma in situ, you are going to call it HSIL. So for both, the follow up is different. For both, the treatment is different. So it is beneficial for the gynecologist to treat the patient. So here you have so you can see some abnormal cells. These are viral laden cells because you can see the light colored cytoplasm, but you have abnormal nuclei. So this is low grade squamous intraepithelial lesions. If you have these viral laden cell, you can say that this dysplasia or this abnormal nuclear morphology is because of the viral infection. These are the endocervical cells, a group of endocervical cell. Here you can see a normal squamous cell. Compare this with the abnormal squamous cells. Here you can see H cell or high squamous intraepithelial lesions. So see this, you have hyperchromasia, you have pleomorphism. The shape of the cell is also changed. Here you can see a superficial squamous cell which is flat, but you have a different nucleus. Here you have columnar cells, but the nuclei they show pleomorphism. So if you have abnormal pap smear, you can go through this scheme. If you have HCL or any glandular abnormality, you go for colposcopy. If you have LCL and the patient is less than 30 years of age, there is no history, previous history of such lesions, you can go for follow-up, and you can have a pap smear in 6 months after that. If the patient has the same lesions in the repeated smears, then you can go for uh, a follow up, which can be 3 monthly, or you can give treatment, or you viral treatment, and then you can go for the pap smear. If you still have the lesion, and you if you have still got the same smear report in the follow-ups, you can go for biopsy of the cervix. So in not in our part of the world, but in the other parts of the world, especially the West, in the US or the Europe, just like self breast examination, pap smear is mandatory for all the women after 30 years of age. So the first pap smear is taken at the age of 30, and then every year you are going to take a pap smear if the pap smear stays normal. If there is any abnormality or viral infection, you go for 3 monthly, 6 monthly, or 12 monthly follow up, as the report says. So this is just a summary what we did till now. You have normal cervix on colposcopy. You have a cancer, you have a low grade and a high grade CIN. So this is a growth which shows carcinoma in situ on colposcopy. This is again a growth which show you more than carcinoma in situ, and you have some bulging prominences on the colposcopy. This can be an invasive squamous cell carcinoma. Here you have a transient infection. This is an ulcer, and persistent HPV infection leads to first carcinoma in situ and then to invasive carcinoma. But that is going to take a long time and a number of mutation before it becomes an invasive carcinoma. HPV is the only cause of cervical cancer. This is a cervical punch biopsy. You take a small piece from the lesion, the growth, the ulcer, or an abnormal area through a colposcopic examination, and then you can go for a tissue examination. You can go for cryosurgery for viral infection, and then you can go for leap surgery to remove only a small part of the cervix which is infected. This is called a cone biopsy. If you have L cell or H cell, and if you have carcinoma in situ on biopsy, you can go for a cone biopsy or a cone removal of the cervix. This is how the cone biopsy is done. You take the entire ectocervix and the lesion, and the patient is saved if the patient is still having carcinoma in situ and there is no evidence of invasive carcinoma. So you are actually going to save the uterine body. This is a full blown cervical cancer, a big growth. In cases of cervix, the most common cervical cancer or the most common cervical malignancy is a squamous cell carcinoma arising from the transitional zone. The transitional zone is the zone between the squamous, stratified squamous epithelium and the columnar epithelium. That is the ectocervix, the junction of the ectocervix and the endocervix. That is where the metaplasia takes place first, which is then converted into dysplasia and then lead to an invasive squamous cell carcinoma. So normal epithelium, transitional zone showing you a lot and lot of quailocytes. Quailocytes means viral laden uh, squamous cells. This is high grade dysplasia, and then you may have a carcinoma in situ and then an invasive squamous cell carcinoma. In cases of endocervix, you may have adenocarcinoma in situ, in which basement membrane is not breached, and then you may have invasive adenocarcinoma. Most common is the squamous cell carcinoma, and second is adenocarcinoma. Adenocarcinoma is arising from the endocervix because endocervix contains gland. This is a well differentiated squamous cell carcinoma showing you keratinization or keratin production. You have adenocarcinoma arising from the cervical endocervical epithelium. This is adenocarcinoma forming glands. We have FIGO staging for cervical carcinoma, and as I told you in the previous lecture, then that in gynecological malignancies you go for FIGO staging. FIGO means Federal International Gynecology and Obstetrics. This is actually a French word, Fédéral International Gynecology and Obstetrics. So you can call it International Federation for of Gynecologists and Obstetricians. So this is actually the same classification as the WHO. So FIGO classification and WHO TNM classification for any tumor. It is the same in case of the gynecological malignancy. So in gynecological malignancy, we just call it FIGO classification. There are only minor differences in TNM WHO classification and FIGO, but uh, that is those are very minor differences. So WHO and FIGO are actually the same at your level. So stage one is that you have an epithelial malignancy, which is involving the stroma, one half or the entire stroma. Then you may have the involvement of the adjacent structure like the vagina or the endometrium. And then you may have the spread of the tumor outside this genital area into the surrounding structure or the pelvis. And then in stage 4 you may have distant metastasis. So this was all regarding cervix or cervical pathology. In case of cervical pathology, you have to remember infections. You have to remember the pap smear and how you take pap smear. You are going to see the technique when you are going to go to the wards in gynecology. In situ cervical dysplasias, the cause of cervical cancer, and then the types of cervical cancer, they are important. So that was all for today, and we are going to stop here, and then we are going to uh, start with endometrium tomorrow in the lecture. I think we did a bit early. So thank you all for a patience listening.